Hello everybody, my name is Mike Filio and I'm joined with Pete Morsuti, both pre-hospital care specialists with SWORBHP. Today we're going to be covering tracheostomy and laryngectomy procedures and hopefully showing you some tips and tricks of the trade. Okay, so talking about tracheostomy patients. So this can be a permanent or temporary procedure and can be put in place because of an airway obstruction, bronchial hygiene, or even just ventilations that are prolonged and need to be in the field. So what's different with a tracheostomy patient is the possibility of ventilating via the oral pharynx and the stoma itself. So there's many different types of tracheostomy and laryngectomy tubes. There can be inner cannulas and outer cannulas, so inner lumen and outer lumen. There can be cuffed and uncuffed, and even specialty tubes. What's important to note is that with a laryngectomy patient, once very well established, they probably won't actually have a tube in place. And if they do, it'll be a much shorter tube without a cuff. So if you're interested in more information in regards to different types of tubes, you can see our Tracheostomy Emergency webinar, which was covered on the SWORBHP website. So when arriving on scene, we want to differentiate between the tracheostomy and laryngectomy patient. You can see that we have a tracheostomy patient here. So this is a great time to go ahead and pull out our emergency flowchart. So there is a difference between the tracheostomy and laryngectomy patient, so let's make sure we pull out the correct flowchart. Now that I've already done so, we're going to apply our PPE, we're going to look, listen, feel for breathing, we're going to go ahead and apply the cardiac monitor, our SpO2, our end tidal, and we're going to go ahead and oxygenate this patient. Then we're going to reevaluate for any further interventions. So when using our emergency flowchart, we bypassed our first section and now we're moving on to oxygenation. You can see our patient here has a tracheostomy in place and we actually have our end tidal and non-rebreather in place. That's because we have one source of oxygen at this time. The preferred method would actually be to use two sources of oxygen if possible, but that may only be available when you get into the back of your truck. Now with this patient, you can see that they have a pilot balloon and the cuff is actually not inflated at this time. That means that the patient can actually breathe from their oral pharynx and the actual stoma itself, which is why we would like to use two sources of oxygen if available. At this time though, we're just going to use one and we're going to quickly extricate to the truck. Okay, so remember with the laryngectomy patient that's well established, there most likely will not be a tube in place. That's fine. So there's no connection between the oral pharynx and the trachea itself. So we're just going to go ahead and oxygenate via the stoma. So with this tracheostomy patient, we've noted that there's increased secretions requiring some deep suctioning. Now this patient meets all the indications to go ahead and apply this. So first what we're going to do is pre-oxygenate our patient. And if we haven't already done so, we're going to prepare our equipment and apply our PPE. Now when performing deep suctioning, it's the exact same for a laryngectomy or a tracheostomy patient. So we've already pre-oxygenated our patient to the best of our ability, and remember, if we have any HMEs, speaking valves, or even an obstructed inner cannula, all of that's going to need to be removed before we do the deep suctioning. So I'm going to go ahead and take off my oxygen mask, and Pete has already pre-sized, and how we do that is we take the inner diameter of our tracheostomy tube, and then we times it by 2. So 8 is our inner diameter, times it by 2, we have 16. And this is going to be our max French catheter that we're going to use. Pete's just sizing this up, so he's going in between the two clavicular heads, and that's going to be our maximum depth. So he's going to go ahead and pre-lubricate with some sterile water. He's going to use his predefined suction settings. So we're going to start at 100 for this patient, and then he's going to go ahead and insert it. Now, as he's inserting it, his patient may cough or he may feel resistance. He's going to go ahead and back up 1 centimeter after that's done, and then he's going to suction all the way out. Now he has a number of attempts to go ahead and try to clear this airway. Okay, so with this tracheostomy patient, we've noted that they need some type of ventilatory support. So We've noted right when we came in that the pilot balloon is actually down. So that means that our cuff is not inflated. So to create a proper seal, we're going to go ahead and inflate it with 5 to 8 centimeters of air. Go ahead, Pete. Great, perfect. And then we're going to go ahead and, if we haven't already done so, we're going to remove our HMEs, our one-way speaking valves, or our inner cannula if it's actually been obstructed. And then we're going to attach our BVM to our 15mm adapter and ventilate. Now what's important to note is with some types of tracheostomy tubes, the inner cannula has to be in place to actually put a BVM on to the 15mm adapter. So as we previously noted with our other tracheostomy patient, some of the 15mm adapters are going to be on top of the inner cannula. So we need to go ahead and have this in place in order to provide positive pressure ventilations. Now with this patient, we're going to go ahead and try to ventilate, but we're going to play this out a little bit. We're going to say that the respiratory effort and ventilations we are providing are not adequate. So we're going to try a different method via the oral pharynx. So with this method, we're now going to put in an OPA, perfect. We're going to go ahead and cover the stoma and try to generate some positive pressure during ventilations. With the well-established laryngectomy patient or even the tracheostomy patient that doesn't have a tube in place, we're going to go ahead and try to ventilate via the stoma itself. Now to do so, we're going to put a PEDS mask on an adult BVM, and we highly recommend the use of end-tidal to try to judge the quality of your seal. Now PEDS ventilating, and this is very easily done in the laryngectomy patient because there's no actual connection to the oral pharynx itself. Now it comes a little more complicated with a tracheostomy patient, and that's because there's an actual connection with the trachea and the oral pharynx. Now to generate the positive pressure that's needed for this patient, we're going to have to go ahead and cover the oral pharynx and the nose itself. So in this case, we failed at ventilation and oxygenation, and we need to go ahead with airway stabilization. Now our patient's not able to do so, and neither is the family members or caregivers on scene, making this patient meeting all the indications for our medical directive. Now, what we want to do is prepare ourselves for success, and that means properly positioning our patient. Now with this patient, we're going to have him sitting up, and we're going to hyperangulate the neck, aligning all the structures, and getting this patient ready for reinsertion of their airway. Now, I've not already done so, we want to pre-oxygenate our patient to the best of our ability and prepare our equipment. So now that we've prepared all of our equipment, we're okay to go ahead with reinsertion. Now, if possible, we want to use a brand new tube. If not, we're going to clean the one that's on scene and reuse it. Now, Pete has our obturator that's already in place, and he's going to go ahead and instruct the patient what he's doing. So we're going to go ahead with reinsertion, and there should be no hang up. You shouldn't feel any resistance. If you do, you want to take this out and restart again. Now it's very important to make sure the obturator comes out, because if it's not, it's a full airway obstruction. And this brain is a Shiley, so we're going to need an inner cannula in place as well. You can go ahead and reinsert that, Pete. Now we've put our end-tidal in place for confirmation, and if we had a cuff, we would go ahead and inflate that as well. Following the successful reinsertion of our tracheostomy tube, we're going to need to secure the airway. You can see Pete here is using Twill ties that are provided with the brand new tube. Now, if those aren't in place, we're going to need to get creative. That may mean using tape or even the elastic band from an oxygen mask. In the unfortunate event that your 2 attempts at reinsertion of the tracheostomy tube fail, the PCP is going to rapidly transport to the closest receiving facility and fall back on their BLS maneuvers, trying to optimize ventilation and oxygenation. The ACP can then move to oral intubation, followed by intubation of the stoma. In the case that oral intubation fails, we're left with intubation of the stoma itself. Now to facilitate this, we're going to go ahead and use a bougie. Now Pete's going to insert the bougie and feel for tracheal rings or a hang up to note that we're in place. Following that, we're going to use a 6 inner diameter tube and secure the airway. Once the tube is in place, we're going to go ahead and inflate the cuff and use our end tidal for confirmation. Perfect. We have good waveform. Now we're going to go ahead and secure the tube and apply our C-collar. Following securing the tube and putting our C-collar on, we're going to go ahead and further secure it to the C-collar and then ventilate with our BVM. Now we're going to rapidly transport to the closest receiving facility. Now, remember, if all of these procedures fail, we're always going to revert back to our BLS maneuvers and rapid transport to the closest facility. If you have any questions, please reach out and contact us. Thanks for joining us today, and take care.